Hey everyone, I am Sahil Golsangi. Now I am presenting a seminar on chronic myeloid leukemia. CML serves as a classic model in oncology demonstrating how understanding a specific genetic mutation can lead directly to highly targeted life-saving therapies. Over the next 15 minutes, we will review its biological mechanism, laboratory findings, clinical presentation and diagnostics. So this is my presentation format. We'll go with introduction, etiopathogenesis and molecular pathology, clinical features, laboratory findings and treatment. Our discussion is structured in 5 key segments. So let us start with etiopathogenesis. CML is characterized by chronic and slow progression. Epidemiologically, it accounts for approximately 15 of all adult leukemias. It shows a slight male predominance with a male to female ratio of 1.4 is to 1 and characteristically presents between the ages of 40 and 60, though it can manifest at any stage. Classification wise, it is a myeloproliferative neoplasm. Common variant is BCR ABL1 rearrangement positive CML. Rare variants include BCR ABL1 negative CML, chronic neutrophilic leukemia, chronic eosinophilic leukemia, chronic monocytic leukemia, chronic myelomonocytic leukemia, juvenile myelomonocytic leukemia. Today our focus is strictly on classical BCR ABL positive variant. So let's discuss molecular pathology. Moving to molecular pathology, CML is a clonal disorder of pluripotent hematopoietic stem cells. The mutation occurs at top of cellular hierarchy, affecting cells capable of self-renewal and differentiation into all three primary cell lineages, which are myeloid, erythroid, and megakaryocytic. The cytogenic hallmark is Philadelphia chromosome, which arises from reciprocal of uh, chromosome 9 and 22. Basically, chromosome 9 has proto-oncogene called BCR and ABL and BCR which is present on chromosome number 22. This resulting the shortened abnormal chromosome number 22 where BCR and ABL merge together and form a Philadelphia chromosome. The abnormal chromosome is Philadelphia chromosome. So the reciprocal mixing of parts of chromosome 9 and 22, the fusion protein of size 210 kilodaltons, also known as P210 protein exhibits excessive protein tyrosine kinase ability to actively compared to normal regulated ABL1 product, which is 145 kilodaltons. As a minor clinical note, a smaller 190 kilodalton fusion protein occurs in minority of cases, which is more frequently associated with Philadelphia acute lymphoblastic leukemia. Clinical features. Clinically, CML is a triphasic disease that traditionally runs in 3 phases: chronic phase, the accelerated phase, and the acute or blastic phase. In initial chronic phases, the symptoms are driven by hypermetabolic state caused by massive leukemic cell turnover. Common symptoms include progressive weight loss, anorexia, and night sweats. Conversely, rare presentations include emergency scenarios like visual disturbance or priapism, precipitated by severe leukostasis when extreme white blood cells count sludge the microvasculature. Physical examination is dominated by splenomegaly, which is characteristically massive and firm. Patient often presents with complaints of early satiety or left upper quadrant abdominal pain due to gastric compression by spleen. Neoplastic myeloid proliferation crowds at normal hematopoiesis, leading to anemia, causing pallor, dyspnea, and tachycardia. We also observe a bleeding diathesis due to dysfunctional platelets. Uh, Manifesting as easy bruising, epistaxis, and menorrhagia. Finally, massive nucleated cell turnover causes excessive purine breakdown, leading to hyperuricemia, which can trigger acute gout or renal impairment. If it is left unchecked, the disease transitions into accelerated phase. Diagnostic criteria are here include worsening cytopenias, basophilia increases beyond 20%, a marrow blast count between 10 to 19%. Clinically, you will note the spleen size increasing despite the blood count control, accompanied by worsening marrow fibrosis and new genetic abnormalities. The terminal stage is blastic transformation, where CML transforms into an aggressive acute leukemia. In majority of cases, it transforms into AML, but one-fifth of the cases are reported as ALL, acute lymphoblastic leukemia. In plastic crisis, traditional tyrosine kinase inhibitors show poor efficacy because resistance develops rapidly. Now, history and physical examination can take us so far. To definitely prove our clinical suspicions, we must perform diagnostic lab investigations. This involves how we test the patient, specifically through a small, simple peripheral blood draw and more invasive posterior superior iliac spine bone marrow aspiration and biopsy. What we are searching for, uh, ranging from baseline cell counts to advanced cytogenic molecular signatures. So, the laboratory findings, let us take a look closely to the laboratory investigations reveal. The complete blood count shows extreme cytosis, frequently exceeding 200 into 10 to the power 9 per liters, leaving a massive dense buffy coat upon centrifugation. The peripheral smear shows the complete spectrum of myeloid cells with highly characteristic bulge or peak in myelocytes and mature neutrophils. The bone marrow aspirate confirms a predictably hypercellular marrow with profound and granulocytic predominance. For definitive diagnosis, we move beyond basic morphology to genetic testings, cytogenic karyotype analyzing. So, for definitive diagnosis, we move beyond basic morphology to genetic testing. Cytogenic karyotype. Cytogenic karyotype analysis reveals 98% of positivity for Philadelphia chromosome. FISH identifies BCR-ABL transcript, ABL1 transcript overlying fluorescent probes. Finally, quantitative RT-PCR is utilized to baseline the exact transcript burden, while routine blood chemistry panels will reflect markedly elevated uric acid levels due to high cell turnover. Let's discuss about chemotherapy. Our first line drug is imatinib, a specific inhibitor of BCR-ABL1 fusion protein that acts as a competitive inhibitor of ATP binding. By blocking ATP, it shuts off the oncogenic signaling pathway, yielding an excellent therapeutic response in over 60% of patients. Newer generation options like nilotinib and dasatinib are also used as first line for deeper initial responses. For patients who fail first line therapy, our second line arsenal includes nilotinib, dasatinib, or bosutinib. If the patient develops highly resistant T3151 gatekeeper mutations, standard TKI fails and ponatinib become uniquely indicated. Rigorous monitoring of tyrosine kinase therapy is mandatory at 3rd, 6th, and 12th month across 3 tiers. Hematological monitoring assesses normalization of blood counts and reduction of spleen size. Cytogenic monitoring looks for complete cytogenic response or CCYR, defined as absolute absence of Philadelphia positive metaphases within bone marrow. Molecular monitoring uses RT-PCR to measure ratio of BCR-ABL1 to normal ABL1 transcripts. We track log reductions to 10%, 1%, 0.1%, 0.01%, and 0.001%, corresponding to decrease of 1 to 5 logs below baseline. A 3 log reduction, that is 0.1%, represents major molecular response. Based on these milestones, Responses are categorized as optimal, warning, or failure, with the latter promoting mutation analysis and drug switch. With modern TKI compliance, the overall progression free survival at 5 years is staggering 85 to 90%. Regarding a potential TK1 related cure, while it effectively renders CML a manageable chronic condition, true treatment free remission is achieved only in subset of patients who maintain deep molecular responses over the several years. Chemotherapy and supportive treatment. To complete our treatment picture, hydroxyurea, which is known as hydroxycarbamide, is an oral cytoreductive agent used for short-term control and of skyrocketing WBC counts in initial chronic phase, but it does not reduce BCR-ABL transcript 1 burden. The only potentially curative open remains an allogenic stem cell transplant, which is strictly reserved for TKI treatment phase or advanced phases to high transplant related mortality. Furthermore, comprehensive supportive treatment is vital. We must aggressively prevent tumor lysis syndrome, characterized by an acute rise in uric acid, potassium, and phosphate, which triggers hypocalcemia and acute renal failure. We manage this with intense we manage this with intense intravenous fluids, alkalization, and allopurinol rasburicase. So, the blood product support, antiemetic support, tumor lysis syndrome, psychosocial support, counseling of patient and relatives are important. Fertility support via banking, round out patient management. Thank you very much for your attention. I conclude my seminar.